Great, thanks so much. Okay, so I'll just get started if that's okay. These are some of the topics that we're going to cover, which is basically cancer of unknown primary, malignant bowel obstruction, metastatic cancer, neutropenic sepsis, renal failure, spinal cord compression, and superior vena cava obstruction. So I'm going to go through oncology and palliative care. This is the oncology section. The most important things in oncology are the emergencies, so which is basically neutropenic sepsis, spinal cord compression, and SVCO. That's the vast majority of what they really want you to know. They don't really expect you to know details of like different cancers. As long as you cover emergencies, that's a good place to start. So a few more people have joined, so I actually will be Menti on. So if you guys, hi everyone who's just joined, if you want to join this, that might be good. Oops, let me just, can you guys see that? Hello, can anyone let me know if they can see and if they can join?
Yeah, I can see that.
Okay, perfect. Has anyone been able to join? Yeah, okay, great. So as I said to anyone who's just come, I'm just recording it for the MedSoc and I'm going to go through cancer stuff first and then palliative care. I don't know if you guys have covered, like, have you done the oncology and palliative care yet? Is anyone here who hasn't covered it, or are you guys doing it or have already done it? Okay, I'll just assume that you guys haven't covered anything and you're completely new. If it's like really patronizing, then just let me know. So I'm gonna move on. Can you guys just, we're gonna start with screening. So can you just dump some screening programs that you're aware of that happen for different cancers? Amazing, great. Great, breast, cervical, anyone got anything else? There's like a couple more I can think of. Prostate, that's interesting. Bowel, yeah, excellent, great. I'm not sure who said prostate. I'm not going to make you own up to it, but I just don't believe there is a like a prostate cancer screening. It's a bit of a controversial one. So does anyone know anything about a test that could be used to detect prostate cancer before it's has symptoms? I want to unmute and just say,
PSA?
yeah, exactly. So do you know anything more about the PSA test, like what it's used for in terms of screening? Or not? That's okay if you don't. I can just say, anyone else? Is PSA used as a screening test?
I don't think it is.
Yeah, exactly. So essentially, prostate, like normal prostate tissue produces PSA, and so does prostate cancer. So PSA levels aren't a particularly good screening tool for prostate cancer because they increase naturally with age as the prostate gets bigger. So if you have benign prostatic hypertrophy, which is the prostate getting bigger as you age, your PSA levels will go up. Also, there's this idea that lots of prostate cancer will never become dangerous. So you can have prostate cancer which is producing PSA, which is not dangerous. So that thinking at the moment is that it leads to overtreatment. So it's not currently used. Men who are over 50 can request it, but if someone requests it in GP, you should do it and also do a PR examination. And you should correlate the PSA level with the age and also the kind of appearance of the prostate on PR, not appearance, but the prostate on PR examination, and only refer if it's concerning for their age and or they have concerning feeling of the prostate. So yeah, PSA level itself is not used as screening, so it's not that reliable. But if someone had symptoms, that's obviously a different question, but as a screening, basically. So just to clear that up, hope that makes sense. Is everyone all right with that? Yeah, hope that makes sense. Going to go back to the PowerPoint and hope you guys can see that now. So as I said, core presentations, and then we're going to go through some screening. We won't cover the 2-week wait guidelines, which is important. So if you guys look up the Macmillan rapid referral leaflet, It's really annoying because they change all the time and they're quite like particular, but you can just have to memorize like when someone will qualify for a 2-week wait for different cancers. That's definitely something you do need to know for the exam, but we're not going to go through it just now because, as I said, it's pretty much just memorizing in your own time. We won't go through every single cancer in this presentation because you cover them within each module, like prostate cancer, you cover it in urology, etc. You mainly need to know the symptoms and like presentation of different cancers. So when in a history you're thinking about cancer, what symptoms do you need to ask about, red flags, stuff like that. In my experience of the oncology module, you do not need to know much detail about different cancers in terms of treatment. We will never be asked questions about treatment planning. So like what chemotherapy for what cancer, or even if this person would need chemotherapy, that they don't expect you to make those kind of decisions. So you don't need to know the treatment in detail. But just presentations of different cancers and 2-week wait guidelines are important. So we're going to go through screening. As you guys correctly said, there's screening for cervical cancer, breast cancer, and colorectal cancer. So again, you need to just go through this in your own time. But colorectal is probably the easiest. Everyone gets a one-off flexible sigmoidoscopy at 55, and then every 2 years you get fit test. Does someone just want to explain to me what a fit test is? Anyone want to volunteer? Basically, you send a kit to the patient, they poo, and then they have a little scoop thing and they put it on the slide and then send it off. This kind of thing is worth knowing because you may be like in an OSCE or something, you do need to know what things are because you may be asked to explain them. So especially things like smear test, colposcopy, just make sure you are aware of what that is, fit test, so that you could explain to a patient, this is what will happen if required. Mammogram, it's 3 early from 50 to 70. As it says, some places are trialing at extended age range, but I think 50 to 70 is pretty much what you would need to know. And if you have significant family history, you might get screened at a younger age. That's fairly straightforward. And then cervical cancer is probably a bit more complicated because the age rate, the gap changes based on age range, but 3 early from 25 to 49, and then 5 early from 50 to 64. You can't do a smear test in pregnancy, so the patient is pregnant, just delay it until 12 weeks postpartum. Sorry, guys, my internet just dropped out. I'm not sure what happened. I will re-share. I was talking about cervical cancer screening. So essentially, um, the cells are tested for HPV, and then if it's HPV positive, you go for cytology. The results of what happens after that depend on the cytology. So if the cytology is abnormal, so any abnormal cells are seen, then the patient is referred for colposcopy. If it's normal, it's repeat in 12 months. So if they have HPV but the cells appear normal, they still need to have a repeat smear in 12 months, which is quicker than the usual screening program. And then if that is again positive for HPV, they would go for a colposcopy. If at any point the sample is inadequate from colposcopy, it's repeated in 3 months. Does that make sense? So this is just like what happens with the results of a smear test. You need to know that. So they can either go back onto routine recall if it's normal, they can repeat in 12 months if it's HPV positive but no abnormal cells, or if there are any abnormal cells, or they've been HPV positive twice, so 12 months and again, they would need to have colposcopy. So that makes sense. So in terms of staging and grading, this is not something that you need to know in detail for every single cancer. You don't need to learn like TNM staging. Have you guys heard of TNM staging? Can someone just explain what TNM staging is? Anyone want to unmute and just say what it is?
It's standing for tumor node metastasis.
Yeah, exactly. And what does that mean?
So like
Yeah.
the tumor, the size of the tumor nodes, like how many nodes it's spread to, or like the groups of the nodes, and then metastasis if it's sort of spread.
Yeah, exactly. Perfect. So the tumor will refer to like the size of the tumor and also whether it's invaded local structures, stuff like that, whether it's broken out of whatever capsule area. The node is groups of nodes, like you said. So some cancers it might be like if nodes above and below the diaphragm are affected, that's a higher N than if it's just one. And then metastasis is always either positive or negative. It's like metastasized or not. So yeah, as long as you're aware of that, and then aware of the difference between staging and grading. So grading refers to like how aggressive the cancer is, so how undifferentiated the cells are, whereas staging refers to how far around the body the cancer spread. Is anyone familiar with Gleason score and wouldn't mind just sharing what it is? Anyone know what Gleason score is? No, I can say. So the Gleason score is something that's used in prostate cancer. So when a sample is taken at biopsy, they look at two different areas of the sample. Well, they look at lots of different areas of the sample and they give it two numbers. So 3 plus 3 is if it's all relatively benign looking. So it's cancer, but by relatively benign looking, like the cells are well differentiated. And then 5 is the most poorly differentiated and most aggressive. They can get two numbers if it's like, so if it was 3 plus 4, it means the majority looks like 3 and some areas look like 4. The reason that's important is because Gleason 3 plus 3, which is all the cells look well differentiated, is very low risk of metastasis. So what I was talking about before about the PSA screening stuff, these sort of like well differentiated, non-aggressive prostate cancer, you're much more likely to die of a different cause rather than cancer. The cancer can just stay there. So it's important to determine what the treatment planning will be and whether like surgery is needed, for example. So that's that one. Moving on, in terms of principles of cancer management, there's different words to describe it. So adjuvant and neoadjuvant generally refers to chemo. So if somebody has the chemo before the surgery, it'll be referred to as neoadjuvant, whereas if they have it after the surgery, referred to as adjuvant. And then curative and palliative is about the intention of treatment. So curative is basically saying that there's an intention to cure, and palliative is that there's not necessarily an ability to cure the cancer, but they're going to have treatment for symptoms. Obviously, you guys know about that. Performance status, I just spoiled that, but there's a Menti. So I'm just going to share the Menti. So if you guys go on this, I have a question, which is basically what, sorry, I just need to find this because my internet broke. Give me one sec. I just need to reshare. So I'm going to share the Menti. So it's basically what is the performance status and what performance status could a patient have chemotherapy at? Just give me one sec. I'm not sure why it's not coming up. Yeah, I'll just ask because I'm not sure what's happened to the Menti. So does anyone know what the performance status is? And could you say what kind of performance status would be relevant for chemo? Like what patient could have chemo and what patient couldn't?
If you have a patient who's usually not on their feet walking around,
Yeah,
they're likely to be a very good candidate for chemo.
yeah, exactly. And do you know what performance status that would be?
Is it 4?
Yeah, so 4 refers to entirely bedbound. So a patient who had a performance status of 4 definitely wouldn't be suitable for chemo. I'm really sorry. I think that you should be able to see the slides now. Can you see the slides again?
Yeah.
Okay, so I'll go through it. The performance status. So basically, you're completely right. So a patient who's 4 is completely bedbound. They're definitely not having chemo. Patient who's 5 is dead. 0 refers to fully active. 1 refers to essentially active, like could do office work or something, but couldn't do strenuous lifting. 2 to 3 is where it gets a bit more, that's basically the only one you have to remember. So if you just remember, 0 is completely active, 1 is basically completely active, 4 is completely bedbound, and 5 is dead. 2 is someone who is able to be up and out of bed or a chair at least 50% of the day, whereas 3 is someone who's in bed or a chair more than 50% of the day. If the person is a 2, then there may be some discussion about chemo, but if they're a 3, then they're definitely not having chemo. The reason for that is because they're likely to die within 30 days of having chemo. They're much more likely to have significant side effects. So it's not recommended for them. This is really important because it's like kind of a general principle that we don't do lots of investigations or offer lots of treatment for cancer for people who are already bedbound or who are not independent with activities of daily living and in bed more than 50% of the day, because the risk of side effects of treatment are really high and it's not beneficial. So the performance status, you definitely need to know this. We had an OSCE station basically about this, so you need to know this and be aware of that principle. In terms of treatment for cancer, you guys all know this. There's basically radiotherapy, surgery, chemotherapy, and immunotherapy. You don't need to know details of immunotherapies, apart from ones that are really common you'll have heard of before, tamoxifen, which is for estrogen in breast cancer. Yeah, and that's pretty much it. Like the common ones will come up, but you don't need to know details. In terms of side effects, can someone I'll just skip out the side. Someone just tell me, if I asked you what the side effects of chemotherapy were, what would you say? How would you categorize them, I guess? Or just shout out any kind of general side effects of chemo.
Nausea, vomiting, hair loss.
Yeah, exactly. So nausea, vomiting, hair loss. Do you have any way of categorizing them, or like making it more systemic if I said what the side effects are?
Maybe by body system. I'm not too sure.
Definitely. Body system is a good way of doing it. The other way of doing it is I would categorize it as early side effects and late side effects. So for cancer treatment, you've got radiotherapy, chemotherapy, and immunotherapy. You can always categorize it by like immediate side effects and later side effects. So for chemotherapy, the immediate side effects affect rapidly dividing cells. So that's the lining of the gut mucosa. So side effects are basically mouth ulcers, vomiting, nausea, diarrhea, appetite loss, and then hair follicles, which is hair loss, and then later side effects, which are with more prolonged courses, are peripheral neuropathy. So if you think about like neurons are just slower dividing than like GI cells. So later side effects would be peripheral neuropathy and also reduced fertility. Then for radiotherapy, immediate side effects are affecting the area where it's been done. So you can get like skin burning and blistering, pain in the area, hair loss in any areas that have irradiation. And then your later side effects are to do with the damage to the tissue in the long term. So increased cancers. So if you have pelvic radiotherapy, your risk of bladder cancer, bowel cancer, etc., is increased in the long term. Then you can get fibrosis of different organs. So fibrosis of bladder or bowel or heart or wherever is affected by the area, which is again later. Immunotherapy, there's kind of these common insignificant side effects, not insignificant, but common less serious side effects, things like rashes. The worry with immunotherapy is like you can get any organitis. So if you think about just taking the brake off the immune system, then it's going to attack stuff. So colitis is important, presenting with severe diarrhea, but you can get any itis like pericarditis, whatever. And that can be really serious, and you always stop the immunotherapy and give high dose steroids. So that's that. This is the chemotherapy bear, which is supposed to help you remember like common side effects based on letters. I've never seen this before, and to be honest, I didn't know about any of these when I did 5th year exams, so I'm not sure. But if you find it helpful, it could be one to look at. Tumor markers. Essentially, they're just like a blood test you can do, and if it's high, it indicates potential for certain cancer. PSA can or cannot be on this list as a prostate cancer tumor marker. Similar to PSA, all of these pretty much are unreliable in the sense that they're never going to be used as a diagnostic test. Some of them are used more than others. Many of them are useful for monitoring response to treatment. So if somebody's had ovarian cancer, for example, 2 years ago and it was treated, and then suddenly their CA125 is going up again, that suggests that they're having a recurrence, which is a bit more useful than using them before the diagnosis is made. Some of them are used though, like for example, if somebody's having symptoms of ovarian cancer or symptoms of prostate cancer, you definitely send your tumor markers off. But as I said, they're not used in diagnosis as such. And you don't do like panels. So if somebody's got cancer of unknown primary, which again, we'll move on to, but basically means that somebody's found to have metastatic cancer and they don't know where it started, sending like all of these off is not really considered useful. Then next thing to talk about, which is review in your own time, but it's talking about paraneoplastic syndrome. So cancers can produce various proteins that cause clinical manifestations. So small cell lung cancer is a big one. It causes SIADH, which is important to know about for sure. That's a common one. So like euvolemic hyponatremia in somebody, think about small cell lung cancer. And then also you've got like pheochromocytoma. If somebody had high blood pressure, you'd ask about these red flags, especially like a young person with treatment-resistant high blood pressure. And also serotonin carcinoid tumors are important. Classically only cause these symptoms when they have liver mets, because if it's in the bowel and it goes through the portal circulation, the liver gets rid of the stuff before it causes the symptoms. So that's like one to know about. The only paraneoplastic syndrome associated with non-small cell lung cancer is hypercalcemia. So other types of lung cancer, the only one they can cause is hypercalcemia. The others are all related to small cell. And then again, another thing to review in your own time, but these are like inherited mutations that put you at increased risk of cancer. So HMPCC is the most common inherited cause of bowel cancer, so that's important. BRCA causes breast and prostate cancer. And then the MEN syndromes, basically MEN1 is 3 Ps, so parathyroid, pituitary, and pancreas. And then MEN2, I just remember MEN2 as two cancers, so medullary thyroid cancer and there's other ones there, but basically medullary thyroid cancer and pheochromocytoma are the only ones that are important. So MEN2, 2 cancers, and then MEN1 is 3. Neurofibromatosis, which is NF1 and NF2, comes up in peds with all the different signs. So it's like a cause of cafe au lait spots. So there's different diagnostic criteria. It's like cafe spots, inguinal axillary freckling, these plexiform neurofibromas and things like that. And it's associated with bilateral acoustic neuromas is NF2, and then pheochromocytomas are associated with NF1. So that's worth remembering because it comes up in peds. The other ones, you can just have a look at them. And then, yeah, that's basically that. So next, some SBAs. I did have a Mendy, but like I said, I don't really know where it's gone, and I can't make it work with the screen sharing because my internet's not working great. So we'll just go through them. So yeah, question 1, 96-year-old man with a background of COPD, heart failure, dementia, and CKD presents with vague abdominal pain. An abdominal ultrasound identifies multiple liver lesions consistent with liver mets. He's bedbound and he has a 4x daily package of care. Which of the following is an appropriate reason not to investigate the cancer further? Anyone want to volunteer and answer? Oh, sorry, I just clicked the screen. Anyone want to say what they think or explain the answer? I've seen it.
Is it the second one?
Yeah, exactly. Exactly. So essentially, this is what we were talking about with the performance status. If somebody has cancer of unknown primary, so they present with metastatic cancer, and they would not be suitable for any kind of treatment, then you don't need to investigate it further. The reason is because any treatment, any investigation, like biopsy or even CT with contrast has risk. So there's no point doing an investigation which is not going to affect the outcome. Yeah, so basically this guy's 93. We know that he's got dementia, heart failure. We also know that he's bedbound, so he's not going to be suitable for any kind of treatment. He's not really going to be fit for surgery or anything like that. So in that case, there's no point in doing investigations. One is not correct because we can't assume he lacks capacity. It would need to be assessed. And also you can obviously make best interest decisions for people who lack capacity. Like if a young person with a learning disability, for example, who lack capacity was physically fit for treatment, they may well get treatment in their best interest. It wouldn't preclude it. 3, he has DNA CPR. Obviously DNA CPR only relates to CPR. It doesn't relate to any other treatment. So that wouldn't be relevant. His presenting complaint was not related to cancer. Then in this case, the radiology fits with cancer, so that's no longer relevant. And then his CKD precludes any investigation requiring IV contrast. That's not true. It's going out of fashion to withhold contrast in CKD. It's more accepted now to give contrast, and you can flush with fluid before and after, discuss with renal, discuss with radiology. So that wouldn't preclude it. Yeah, so different types of investigation that can be used in cancer of unknown primary. So the most important thing is to take a good history and send tumor markers as appropriate to the presentation. So you're going to send full blood count, uni, LFTs, calcium, because metastatic cancer to bone causes hypercalcemia, and also, like I said, lung cancer can cause hypercalcemia as paraneoplastic. So you want to know that, and also myeloma and stuff. So send calcium, LDH, and then specific tumor markers, which is PSA, CA125, so prostate, ovarian, depending on obviously male or female, and then AFP and HCG. That's because AFP and HCG are for testicular cancer, and testicular cancer responds very well to chemo, even if it's advanced and metastatic. So you're sending that to pick up something which is treatable, even if it's metastatic. So if it was a man, you send PSA and then AFP and HCG, and then someone with ovaries, woman, you would send CA125. You're going to do myeloma screen, and then chest x-ray, CT cap, like I said, testicular ultrasound if relevant, and then you might do top and tail endoscopy, so endoscopy and colonoscopy. Essentially, you're targeting places where the primary could come from. So in addition to these, you would want to consider things like a breast exam in a woman, see if you can find a primary. According to NICE, you should only investigate if the patient will be eligible for treatment, and also they want treatment and they understand why they're having the investigations done. If they're not fit for treatment, it doesn't mean that you do nothing. You still refer to palliative care and obviously provide them with psychological support. Okay, moving on, try and go a bit quicker. We're going to go through the emergencies, which is actually the most important thing to know probably the most tested thing. So first question, 75-year-old man has come to A&E complaining of sudden onset severe abdominal pain, and a few hours ago and is now vomiting. He has a 3-month history of changing bowel habit and weight loss. He's got tenderness, palpation, and tinkling bowel sounds. Considering the most likely diagnosis, what is the most important diagnostic investigation? Anyone want to volunteer an answer?
I'm not sure, but I think we're worried about an obstruction.
Yeah, absolutely.
By probably a mass.
Yeah.
So would it be an abdo X-ray?
So an abdo X-ray is not a bad idea. It definitely might show a obstruction. However, it's not the most appropriate diagnostic investigation. So this is a like kind of SBA technique question. UCL love questions that are, what is the most appropriate initial investigation, or what is the most appropriate diagnostic investigation? So for a diagnostic investigation, you want the investigation that gives you the diagnosis, no questions asked, like that's the diagnosis. So a CT abdomen gives you more information than an abdominal X-ray. So even though an abdominal X-ray is an entirely appropriate initial investigation, in this case, it's less likely to be diagnostic than a CT. So the answer would be CT. And that's why, because the wording of the question is most appropriate diagnostic investigation. So an abdo XR is not wrong, and it may show obstruction as in dilated bowel loops, but it's not as likely, well, it's not going to be able to show you the mass, like you said, the tumor. So CT is more likely to show you the tumor. So it's more likely to give you a diagnosis. All of the others are actually appropriate, to be honest. Like you definitely would send bloods. Abdominal US may be less likely, but again, you may do a colonoscopy if you were later down the line for treatment planning and identifying and stuff. So none of these are necessarily wrong, but the most appropriate diagnostic investigation is a CT. So yeah, really important to read the wording in the question. Technically as well with cancer questions, oncologists only, they want tissue. So a biopsy, which gives you tissue, is always more diagnostic than any scan. So if there was something like, you know, you wouldn't do it in acute obstruction, so it's not relevant. But if there was, which is more likely to diagnose bowel cancer, colonoscopy and biopsy, or CT, then a biopsy that gives you tissue is always more definitive for diagnosis than a CT, because obviously any lump on CT can be benign. So they always want tissue to show that. So in terms of management, large bowel obstruction, most common cause is tumor. Small bowel obstruction, most common cause is adhesions, but in large bowel obstruction, definitely thinking about colorectal cancer. Bowel obstruction, I'm sure you know from 4th year, but presents with absence of stool, especially lower down. You're going to get that earlier. Nausea and vomiting, you're going to get sooner if it's higher up, but definitely absence of stool, abdominal pain, distension and parotidinism. CT abdomen is better at diagnosing the reason for the obstruction. In terms of management, drip and suck, so make them nil by mouth, NG tube and IV fluids, classical A to E stuff. Get fluid balance, and then refer to surgery. Next question. A 65-year-old male with a history of prostate cancer presents at A&E with severe back pain, which has been increasing in severity in the last couple of weeks and keeping him awake at night. On examination, it's clear that there's bilateral weakness in both legs with reduced sensation peripherally. Considering the most likely diagnosis, what is the first best step in management? Anyone want to say?
Would it be DEX?
So DEX is definitely what you do, but again, they've said total bed rest. So I think this is again getting at like UCL SBA technique. So because it says the first best step, then you would immobilize the patient in order to kind of reduce the risk of any incivility. So they basically just said bed rest, but DEX is the appropriate treatment. Do you want to explain what is going on here? What does the guy have? Anyone want to say what's going on? Why is he presented in this way?
He probably has mets in his spine that are obstructing his spinal cord.
Yeah, exactly. So he's got acute spinal cord compression from bony mets. So in terms of managing this, all of these, well, not so much X-ray, but all of the others are definitely appropriate. So principles of management. The most likely cancers to cause acute spinal cord compression, which is one of the most important oncological emergencies that you need to recognize and know how to manage. So your cancers that most likely to cause it are breast, lung, thyroid, kidney, and prostate. Symptoms of back pain, which is worse lying down. So that's a red flag. Normal back pain is worse moving around. So if the back pain is worse lying down, that's a red flag. And when coughing or straining, it gets worse. Limb weakness, it should not be acute or bilateral. So like disc prolapse can cause some degree of limb weakness, like a foot drop, for example, but acute and bilateral limb weakness is always a red flag that you need to immediately send that person to A&E. And obviously you guys know about cauda equina, bowel and bladder dysfunction is a red flag. Again, it says cord ends at L1. So in metastatic spinal cord compression, you can get either cauda equina or acute cord compression, depending on where in the spine the mets are. But yeah, if you've got upper motor neuron signs in the legs, that's acute spinal cord compression. So your investigations, you need an urgent whole spine MRI. So the idea is that if there's mets to one area, there's likely to be mets to other areas. So you need MRI of the whole spine, not just the area you think is affected. And then in terms of your like conservative medical surgical management, so conservative management, you need total bed rest to immobilize the spine, because any bone affected by mets is likely to be unstable and could result in a fracture and further damage. So immobilize and discuss with neurosurgery immediately, because they need to decide if the spine is stable or not. So that would be your first thing, would be arrange the whole spine MRI and then immobilize the patient and discuss with neurosurgery. They won't let the patient have any kind of physio or anything like that unless neurosurgery have said that they can move around. The next thing is to give the medical management. So giving them a huge dose of steroids, so 8 milligrams BD steroid, which the idea is it reduces the edema around the mets and then reduces the compression. You need to give PPI with that much steroid. So just think about side effects of steroids. Definitely prescribe PPI. And then refer to your onc team basically to decide what would be appropriate. Sometimes patients are suitable for surgery, but most often radiotherapy can be offered for palliative reasons, because once it's metastatic, obviously it's palliative treatment. So those are the principles. Discuss with neurosurgery, discuss with oncology, immobilize, give dexamethasone, give PPI, give pain relief as well, and organize your whole spine MRI within 24 hours. Next, okay, 28-year-old female has been diagnosed with Hodgkin's lymphoma. Prior to starting therapy, the oncologist advised her on the risks of tumor lysis syndrome. Which medication can be given to prevent this from happening? Anyone?
Is it one?
Yeah, it's one. Exactly. So allopurinol is given PO or IV before within a few days of chemo to reduce the risk of tumor lysis syndrome. It's not given to every single person having chemo. There are cancers that are higher risk of tumor lysis syndrome. So it tends to be leukemias and lymphomas, like acute leukemias and lymphomas, where you've got a huge amount of cells that are about to burst when you get chemo. What it is, it's massive destruction of cancer cells, releasing all their contents into the bloodstream. And like I said, this is usually heme cancers where it's a concern. The cells have burst, so they're releasing uric acid, phosphate, and potassium. I remember tumor lysis syndrome, like everything is high, and refeeding syndrome, everything is low. So it's the opposite. In refeeding syndrome, you have low phosphate, low potassium, and then tumor lysis syndrome, high phosphate and high potassium. So like the cells have burst and released all their contents. So intracellular stuff goes into blood. It causes presents nausea and vomiting, weakness and diarrhea, and it causes an AKI. So that's the risk, is that you get a big AKI from it. So in order to prevent it, the patients are given lots of fluids. They're given allopurinol beforehand, which reduces the uric acid level, promotes excretion of uric acid, and then reduces the AKI basically because of that. You can also give IV respirocase as an alternative, but this would mainly affect patients who are having chemotherapy for hematological cancers. Okay, so next, a 55-year-old woman has presented to A&E severely unwell. She recently undergone chemotherapy for SCLC a few weeks ago, but it's been fine until recently when she's been spiking fevers of 39 degrees. Considering the most likely diagnosis, what is the most appropriate first step in management? Anyone want to say? Or anyone want to say what this is, what is going on here?
She probably has neutropenic sepsis, right?
Yeah, exactly. She has
I'm trying to figure out whether you do blood cultures first or give antibiotics.
Yeah, I know. It's really annoying. They've said antibiotics. I think that's because the question says management. So blood cultures are definitely the appropriate investigation, but in terms of management, Tazocin is the management. So I think that's why it's 3. She has neutropenic sepsis. Do you know what the definition of neutropenic sepsis is? Or does anyone? No, I can say. So essentially, neutropenic sepsis is patients who've had chemo and they've got neutrophils less than 0.5, and they present with a fever or signs of sepsis, clinical signs of sepsis. So you suspect in anyone who's had chemo, especially in the last 7 to 10 days, that's kind of like the risk range, who comes to A&E with a fever or signs of acute infection, you're immediately thinking about neutropenic sepsis. Like I said, the definition says the neutrophils are less than 0.5, but you wouldn't wait for that. You would, if someone's had chemo in the last 7 to 10 days, you wouldn't wait for that. And then if they've got a fever or any signs of infection, you'd immediately do sepsis 6. So you're going to do all of these things apart from amoxicillin because you're giving Tazocin instead, but you're going to do your 3 out, 3 in. So get a VBG, get a lactate, get a fluid balance catheter and blood cultures, and then give IV fluids, antibiotic, and oxygen if required. You also want to try and localize the source. So you basically do a top to toe. So you'd get ask them about any respiratory symptoms, get a chest x-ray, auscultate, abdominal exam, stool sample, urine culture, swab any lines. Like a lot of cancer patients have long lines. So think about removing lines and culturing them if there's any sign of infection. You want to think about wounds, cellulitis, also a respiratory swab for viruses, which is a differential, another reason why someone might have a fever if you don't find a source. So literally just a top to toe investigate, try and find a source, and then yeah, so they say 7 to 14 days after chemotherapy. I've said 7 to 10, but something like that. Definitely consider with recent chemotherapy and a temperature, and then do blood cultures and then identify any source. If they're not responding in 4 to 6 days, then you consider fungal. So you might consider like capsifungin or something on top of antibiotics, but obviously that's like discussion with a micro. And they said order higher resolution CTs to look for fungal infection, but I think that's a bit small print. This is generally what what you need to do. Yeah, Tazocin, and then if they're pen A, ciprofloxacin IV, and can add gent if they're severely unwell. Some patients get GCSF, which is colony stimulating factor, so it just helps boost neutrophils around the time of chemotherapy. Again, that's like an add-on treatment. So as long as you do the sepsis 6 and give the initial antibiotics, that probably wouldn't be your decision as an F1 to give GCSF. Okay, next. A 68-year-old male has noticed that in the last couple of days, every time he goes on to raise his arms above his head, he becomes severely swollen and red in the face. On top of this, he's had a few months' history of coughing and becoming increasingly short of breath. Considering the most likely diagnosis, what would be the best management? Anyone know this? Or anyone want to say what they think is going on or what the diagnosis is? Hello, anyone there?
Someone put SVCO in the chat.
Sorry, I didn't see the chat. Thanks, perfect. SVCO, so superior vena cava obstruction. Exactly. So when he raises arms above his head, that's called Pemberton sign. So SVCO is basically where you've got, it's a mediastinal cancer, usually small cell lung cancer. It's growing and compressing the superior vena cava, reducing the venous return to the heart. So you get symptoms, breathlessness, swelling in the arms and face. If you ask the patient to raise their hands above their head, they become really red in the face, which is, like I said, called Pemberton sign. Also coughing, things like that related to the cancer itself. So yeah, the answer is dexamethasone. So that's the same answer for the spinal cord compression. So dex, it's basically high dose steroids, give PPI. If you think about different steroids, they have different effects on like mineralocorticoid system and also their cortisol effect, like they have two effects. Dex is much less effective on the mineralocorticoid system, so it doesn't cause fluid retention, it causes fluid loss, or like getting rid of fluid. That's how I remember it anyways. Like hydrocortisone, you give that in Addison's disease because it helps with the aldosterone lack as well as the cortisol lack, whereas dexamethasone has no mineralocorticoid activity. So if you want to get rid of fluid, you want to give dexamethasone. So yeah, high dose dexamethasone with PPI for either spinal cord compression or also SVCO. It'll reduce the compression. And then further down the line, it says here you can consider stenting. So if the patient is for palliation, then you can put a stent in to help reduce the symptoms. Often this is caused by small cell lung cancer. So they will give chemo to these patients, even if they're basically on death's door, because they respond, small cell lung cancer responds really well to chemo or like radiotherapy and stuff like that. So they'll give treatments if it's small cell lung cancer, because the cancer will shrink quite rapidly and that can obviously relieve the symptoms. So yeah, things to ask about in a history or to look for in the SBA stem would be shortness of breath with orthopnea, stridor, headaches, swelling, and also like distended collateral veins, which would happen if it developed a bit more slowly. And then you're going to do chest X-ray and CT to find out what's going on, and then give dexamethasone and discuss with oncology. Okay, that's feedback, but we'll move straight on because for the interest of time and do feedback at the end. So does anyone have any questions about the oncology section before we move on? Essentially, the most important things are the emergencies, which we went through. So SVCO, spinal cord compression, and neutropenic sepsis, and also bowel obstruction. And then general principles in regards to treatment. You don't need to know like specifics for specific cancers. Any questions? Or put them in the chat. Before we move on. No? Okay, I'll move on to palliative care. So we're going to go through main symptoms in palliative care, also opioid conversions, syringe drivers, and TTAs. Not really going to go through TTAs, but it's on there. So this next question, an 80-year-old female has end-stage lung cancer, which does not qualify for further treatment. In the last couple of days, there have been discussions of palliation. However, in the meantime, your consultant has asked you to prescribe anticipatory medications. What is the most appropriate combination of medication? Anyone want to say or put in the chat?
Is it one?
Yeah, exactly. Perfect. So one is morphine, midazolam, glycopyrronium, and cyclizine. So anticipatory medications are medications prescribed at the end of life, which treat the main symptoms that are a problem at the end of life. So that would be pain, agitation, secretions, and nausea. So in terms of management of end of life symptoms, like I said, these are your four ones to know about. Pain, consider the pain additive one is that end of life. It's going to be opioids. Nausea and vomiting. It says ideally prescribed two with different mechanisms. Cyclizine is always a good idea, in my opinion. Just go with cyclizine. Agitation and restlessness. Midazolam and secretions, you can give any one of these. In terms of these, you just need to know that I suppose you could get an OSCE where you have to prescribe these, in which case it's kind of worth having a favorite one. So knowing them off the top of your head, so at least you can look them up quickly in the BNF. When you prescribe these, if the patient isn't needing them yet, you prescribe them on the PRN side, so that they can be used if necessary. So if you ask to prescribe anticipatory medications, then you put them on PRN for a patient who may need them if they develop these symptoms. Yeah, so essentially, at the end of life, focuses on comfort. So you stop observations and bloods, only give IV fluid if it's necessary for the patient's comfort, prescribe anticipatory medications, so one from each of these 4 categories on the PRN side, and then don't give any medication that's not necessary. So continue insulin in type 1 diabetes, but you would shift the target. So blood sugar target at the end of life is like 10 to 15. So the idea is to minimize symptoms from either hypo or hyperglycemia. So you would want like a more relaxed target than in normal situations. And then obviously consider like involving family, friends, the patient's wishes, and any spiritual needs. In terms of agitation and restlessness, they just address the basics. So address all causes of delirium, which you cover extensively in COOP if you haven't covered already, but essentially urinary retention, constipation, bloods being off, any electrolytes being off, hypoxia, various drugs that you might be able to stop that may help delirium, and then basic like things like sleep-wake cycles, so ensuring that there's like natural light if possible, or at least that they're not in fluorescent light all night. And then if you can't do any of those, haloperidol is good for managing agitation if conservative measures don't work. So like having somebody speak to the patient, etc. If they can't be settled and they're a risk to themselves or other people, you can give haloperidol. However, in palliative care, so in kind of like end of life, then midazolam is the first choice. So yeah, give that and you give it through a syringe driver. Another problem at the end of life is secretion. So while the patient's breathing, they make a rattly noise because they've got upper airway secretions. Often the patient themselves isn't actually distressed by this, as like that's kind of the general feeling among, I mean, I don't know how you ask someone if they're finding that distressing, but the general feeling is it's not distressing to the patient, but it can be distressing to the patient's relatives. So you can do conservative measures, which include positioning on their side or sitting up and suctioning. And if those things don't work, then you can give an anti-muscarinic to basically, an anticholinergic to basically help with this, reduce the amount of secretion. Nausea and vomiting, again, treat underlying causes if possible, otherwise give antiemetic and a PRN antiemetic. There are loads of different antiemetics. They have loads of different mechanisms of action. I never learned any of this in much detail. I just learned that cyclizine is good for everyone in all situations. So cyclizine is my favorite. You can always do it. There's not really any significant contraindications. You can't give prokinetic antiemetics in bowel obstruction. So things like metoclopramide, you can't give in bowel obstruction. You can't give it to people with Parkinson's. So there are different ones that have like different contraindications, but cyclizine is pretty much all purpose. So that's the one I would just default to in an OSCE if you need to look something up. So yeah, this kind of goes through different mechanisms. Again, I didn't really memorize any of this. I just would go for one, learn the dose, learn the contraindications, use that one. I did learn that ondansetron is good for chemotherapy related nausea specifically. So in someone who's not end of life but is having chemo and has nausea, ondansetron is useful. And then yeah, you can add on a second line on top of cyclizine if necessary. As I said, don't give metoclopramide or domperidone to people with bowel obstruction or Parkinson's. And they also have risk of, because they act on dopamine, that's why I can't give them people with Parkinson's, and also they can cause acute dystonic reactions in young patients. So that's something to be aware of. This is the WHO pain ladder. So the principles of pain relief and palliative care is like by clock and by ladder. So you prescribe regular pain relief according to this ladder. It starts with paracetamol and ibuprofen. It goes to a weak opioid, so codeine or dihydrocodeine or tramadol sometimes. And then if that doesn't work again, you give them morphine or another alternative strong opioid. The main things to say about this are that this is validated for cancer, chronic pain. This is not to be used in other situations. So if a young healthy person comes into A&E with like appendicitis, you don't need to give them paracetamol and see if it works before you give them codeine and see if it works before you give them morphine. Like a young healthy person, previously healthy with appendicitis, it's perfectly appropriate to give them like a one-off dose of morphine straight away. You don't need to always follow this, but it's used in chronic pain and cancer pain. So yeah, you would start by giving paracetamol and ibuprofen, then escalate to codeine, which is a weak opiate, and then escalate to a strong opiate if that doesn't work. You can also give alternative like neuropathic agents like gabapentin and stuff alongside it at any point. And also you carry on your paracetamol and ibuprofen even while you're giving morphine. Like there's nothing wrong with giving some background paracetamol. It's not going to do any harm, and it may reduce the amount of morphine that's needed, so you can carry that on as you escalate. Yeah, so question: a 75-year-old man with end-stage renal disease with a history of prostate cancer comes in with severe back pain. Which opioid is the most appropriate to give in this situation? Anyone want to put something in the chat or say? For fentanyl, yeah, exactly. So morphine accumulates in renal disease, so you have to be careful with it. You can, if they have like mild renal impairment, you can start a lower dose. Or if they, for example, developed a mild AKI while on morphine, you could reduce the dose and increase the dose interval. So give it 3 times a day, whatever, increase the distance. But if they've got really severe, like no renal function, then you need to give an alternative. So oxycodone and fentanyl are both suitable. But fentanyl is most suitable in this situation because the eGFR is less than 10. So yeah, fentanyl would be required. In terms of strong opioids, the general pattern of doing it is morphine first for most people, unless they have severe renal impairment. If that doesn't work or it has side effects that are not well tolerated, then you can switch into a different strong opioid. As an F1, you're not, I don't think you need to know about strong opioids. This is like a palliative care kind of discussion. You just need to know basically how to prescribe morphine. You need to know that morphine is contraindicated in severe renal impairment and what would be used as an alternative. And you need to know the side effects of morphine. So worth looking at the side effects of morphine and knowing them. In terms of like the intricacies of different side effects with different strong opioids, I don't think it's like necessarily something to, I mean, it can always come up in an SVA, but I don't think it's like core knowledge. But yeah, basically, when you give morphine, it comes in different preparations, and there are different ways of giving it. So when you start somebody on morphine, you start everyone on this is for chronic pain. So again, I'm not talking about someone coming to A&E with acute pain, but in somebody who's got cancer pain, which is not controlled, you're going to start them on by mouth, by the clock, immediate release, Oromorph. When I say not controlled, you've tried paracetamol and ibuprofen, you've gone up the ladder and they need a strong opioid. So you're going to give morphine, unless contraindicated by renal function, every 4 hours. You start them off on a starting dose every 4 hours. So for most people, it's going to be 10 milligrams every 4 hours. If they are elderly or opioid naive, so they haven't been taking codeine, or slightly renally impaired, you start them at 5 milligrams every 4 hours. And then when you prescribe morphine, so on the regular side, you're going to put 10 milligrams every 4 hours, Oromorph. You also give them something that they can use if their pain isn't controlled between their regular morphine. So you're going to give them 1/6 of the daily opioid dose as a PRN. So essentially, if you were starting somebody off on 60 per day, so a young healthy person, not young healthy, but a young non-renally impaired person, you're giving them 10 milligrams 4 hourly, you'd be giving them 16 24 hours. So you give them 10 as a breakthrough dose as well. And you write an indication for that. So if pain, between doses, they can have a PRN dose, and also a maximum frequency. So I've seen different things written for that. Generally, it's hourly is the maximum frequency for PRN, but they may write something like give 2 doses in 4 hours, and if requiring more than that, then escalate, because obviously you want the nurse to call you if the patient's suddenly having much more severe pain than they were, and you want to review them rather than just keep on giving them morphine. Once the pain is adequately controlled, you swap them onto modified release morphine. So you add up all of the morphine they've had in 24 hours, that includes their regular and PRN doses, divide it by 2, and then give it in 2 doses. So 1 in the morning, 1 in the evening, and then add give them a PRN option as well, to make sure that they can have something if they're still in pain between doses. We'll go through some examples of that. I don't know if you guys have been taught that before, if it's brand new. If it's brand new, it's a bit confusing at first. So I'll go through some examples. But this is a conversion chart to be sort of aware of. The conversions are different from different sources sometimes. So yeah, worth knowing for sure that codeine to morphine is 10-1. That will be something that you will be required to calculate. If the patient's already on codeine, what's their morphine dose going to be? That could definitely be a question. So 10-1 for codeine to morphine. Oxycodone is about 2-1. That can vary a little bit between sources, but for sure also worth knowing that morphine to subcut to oral is 2-1. So if you were switching them from oral morphine to a syringe driver, you need to divide by 2. We'll do a task. So I'm going to give you like 2 minutes if you just want to get some paper and jot this down. A 65-year-old male with terminal lung cancer is admitted to hospital for pain management and doesn't have his pain relief. He's currently on 60 milligrams of codeine 4 times a day, paracetamol 1 gram, and ibuprofen 200 milligrams. Your consultant has asked you to put him on regular morphine, as well as ensuring adequate PRN cover. You're also required to prescribe all the additional appropriate medication. So I'll just give you like 2 minutes to jot down what you think you would prescribe. So yeah, all the things you need to prescribe: an opioid, the regular meds, anything else that you might think of considering prescribing. Yeah, and then I'll ask if anyone just wants to like put their hand up or put something in the chat or shout when you've done it, and then we can discuss. Okay, anyone want to say what you've done or put in the chat? Firstly, how much morphine did you prescribe and how did you prescribe it?
So for morphine, I think I wouldn't classify this patient as opioid naive.
Mm-hmm.
So I would give them 10 milligrams 4 times a day with a maximum of 60 milligrams per 24 hours
Mm-hmm.
of Oromorph, I think. So, well, yeah, no, I think 10 milligrams of Oromorph every 4 hours.
Mm-hmm.
And then for breakthrough pain, you can do a 10 milligram opioid in addition, just based on before. But I think the maximum still 60 milligrams for 24 hours. Like you can't then give 120. with breakthrough pain, can you? Because that would be too much.
Yeah, so basically, you're definitely thinking along the right lines. In this question, they wanted you to calculate because they're already on codeine, they wanted you to calculate. I probably didn't make that very clear here when I was saying if they're not opioid naive, but if they're already taking codeine regularly, you can calculate based on how much codeine they've had. So you can divide by 10 to work out the morphine, if that makes sense. In terms of this max 60 milligrams for 24 hours. So I'm not sure about that. From what I've seen, it's 10 milligrams every 4 hours with 10 milligrams as the PRN dose. And then, like I said, they might put something like max 2 hourly for the PRN or max 2 doses in 4 hours. But really, if you're titrating up, then you want the patient to have well-controlled pain. There's no max in 24 hours as long as the patient isn't getting side effects. So you can give them as many PRN doses, obviously not more than hourly because you need to give it a chance to work, but you can give them as many PRN doses as required in 24 hours to control the pain. And then once you've got a total amount in 24 hours, you can start giving it regularly. You would increase the regular dose. So yeah, I'm not really sure what that means, and I've not really seen it used. Obviously, if the patient's getting the patient's going to be monitored in hospital for side effects. So yeah, I'm not sure why they put that, but I think it refers to if you're starting someone off on 10 milligrams 4 hourly, they would get 60 milligrams in 24 hours. I don't know. And then plus the PRN doses. But yeah, if you're converting them from codeine, this patient's on 60 milligrams of codeine 4 times a day. So how much morphine is that equivalent to? Anyone want to just shout?
6.
Yeah, so exactly 6 milligrams 4 times a day, so 24 in 24 hours. So you would then divide that 24 by 2 to get the morphine. By 10 to get the morphine. So they've had 240 milligrams of codeine in 24 hours. So divide by 10, 24 milligrams of morphine in 24 hours. You can then, they've said you can prescribe it twice daily, but I don't think that would really be done in practice because the patient hasn't yet got well-controlled pain. So here it says exactly what you were saying before about 10 milligrams every 4 hours. I would start that regime first and then only convert it to twice daily once the pain was controlled. So yeah, so you basically would put them on an equivalent, which is like they're on 6 4 times a day at the moment. So you could put them on either 5 or 10 every 4 hours. And then you would give them breakthrough doses as well. So you need to give them PRN. You also need to start a laxative and an antiemetic. So don't forget to prescribe that, along with also the patient was already on paracetamol. So I would prescribe the paracetamol. So if you're doing this as a conversion, you basically add up all of the codeine they're getting in a day, so 240, divide it by 10 to get the amount of morphine you're getting in a day, which is 24. And then you would prescribe that 4 hourly, and then with the breakthrough dose as well. And then prescribe their paracetamol and prescribe a laxative and antiemetic as well. These numbers aren't like that easy. I think they'll give you like multiples of 10 in the exam to make it easy so that it works out as something quite easy, like 10 milligrams every 4 hours plus 10 milligrams PRN. So I hope that fits, basically gives you the general principle, which is you just work out how much codeine they were on, how much morphine equivalent they were on, and then give the morphine divided into 4 doses or 6 doses 4 hourly and give a PRN. It doesn't really matter as long as that you're giving them an equivalent amount. I hope that makes sense. It's a bit tricky on Zoom, but I hope that kind of what you said is appropriate. So giving them 10 milligrams 4 hourly and then the breakthrough. This is another kind of converting regular to twice daily, or syringe driver. So once the patient's on 4 hourly doses with PRN and they're controlled, you've got like an opioid in 24 hours. So you can then convert it to twice daily modified release, or in this case, a syringe driver. So yeah, asking what would be appropriate for a syringe driver for this patient. So first step is to calculate the morphine in 24 hours. Which would be 80. And then does someone want to shout out what the answer would be? Or put it in the chat.
Is it 40?
Yeah, exactly. So for a syringe driver, you're going to convert to the subcut dose, which is divided by 2. So calculate your total dose in 24 hours and then divide by 2. So a note about syringe drivers. Subcut is preferred to oral medication at the end of life because it doesn't require swallowing or GI absorption. Basically, what you do is just prescribe, you site the syringe driver anywhere with like adequate amount of subcutaneous fat, so like upper arm, something like that. And then you're going to prescribe the syringe driver with the medication over 24 hours. You can put all of the drugs in the syringe at the same time, so all of the 4 anticipatory, so pain, nausea, agitation, secretions, you can put all 4 drugs in the same driver and then just run it over 24 hours. There are like, you can look up what drugs can be put in the same syringe. I don't think that in a 5th year OSCE they would ask you to prescribe all 4 drugs for a syringe driver. That kind of feels mean. But as far as I'm aware, the most commonly used, so like morphine, cyclizine, glycopyrronium, midazolam are all able to be combined. But in practice, it'll be palliative care who can tell you like exactly what combinations are allowed in one syringe driver. But this is how you prescribe a syringe driver. So it's a bit different to a normal prescription. But in the fluid section, you write exactly this. So made up to 24 ml with water for injection, says injection for water, but water for injection to run by a continuous subcutaneous infusion over 24 hours at a rate of 1 milliliter per hour. And then you would write in morphine 40 milligrams, sign it, cyclizine 150 milligrams, whatever you're giving, put it in and then sign. You also with this, I think this is in the practice, but here you've prescribed your regular morphine, you've prescribed your antiemetic because you're giving cyclizine. Laxative isn't relevant because if they're having a syringe driver, it means they're not taking anything orally, so you can forget about that. You still need to prescribe PRN with a syringe driver. So you essentially calculate 1/6 of the 24-hour dose of morphine and prescribe it as PRN to be given at a different site. So they would just use a syringe, a different subcutaneous injection at a different site to give the PRN dose. And then you just write that in the indication. So I don't know if you guys want to have a go at this practice. So a 92-year-old man with terminal Parkinson's disease has been admitted with aspiration pneumonia. He continues to deteriorate despite best medical management, and the team place him on end of life. His anticipated and regular medications are no longer working, so he needs a syringe driver. And this is his current morphine use. And you need to work out how much morphine to put in it and also what other medications. So I'll give you a sec to look that up in the BNF, the dose of other medications, and also calculate the morphine. Okay, hopefully that was adequate amount of time. Anyone need a bit more time? Okay, hopefully you at least had a go at that. You basically need to prescribe the 4 medications. So this is what you'd put in the syringe driver: morphine, cyclizine, hyoscine hydromide or glycopyrronium or whatever, and then midazolam. And then you can look up the dose for secretions and agitation in the BNF and also for cyclizine. And then morphine, you'll calculate according to the patient's use. So they had previously been using their 2 regular doses and their 4 PRN doses, which came out to a total of 32. So you divide it by 2 to get the correct amount for subcutaneous, and then that's what you're going to put in. And then don't forget to write the PRN dose on the PRN side. So if you go back to this is what you would write. So you just need to memorize this: made up to 24 ml with water for injection to run by a continuous subcutaneous infusion over 24 hours at a rate of 1 ml per hour. And then you write in the 4 drugs and the correct dose. And then on the PRN side, you would prescribe your PRN morphine. Oh yeah, it says it here. So you've got that. And it says, good practice to write an additional information in PRN so everyone knows what it's indicated for. You actually have to write an indication in PRN. So that's if you're giving any PRN drug. So for example, for the if you're giving morphine and you're writing up a PRN antiemetic like oral morphine, you have to give an indication. So you have to write for nausea, because the nurse can't give it if they don't have an indication, because obviously the patient has to say I'm nauseous and then the nurse has the indication there. Otherwise they'd have to bleep you. So you must write an indication. So you would write for pain, and then they've put review analgesia if pain not controlled. So I probably write something like for pain, maximum frequency hourly, give it a different site to subcutaneous, to syringe driver. If requiring more than 2 doses in 4 hours, please bleep doctor. Or if doses, if pain uncontrolled, bleep doctor, something like that, so that they know that if the patient suddenly experiences severe pain, they obviously need to be reviewed. Yeah, so I hope that makes sense. This is a bit tricky. To be honest, I'd probably just go through the slides later, or if you have other teaching when you do the placement, or if you did the placement, then go through this. It's a bit fiddly, but once it's fairly straightforward once you know what you're doing, and it definitely could be an OSCE prescribing this, so worth knowing. The next thing, almost at the end, is just controlled drugs. So this is a GP prescription form. You always have to write the same things. So you always write the patient's age and date of birth, and then their address, just fill in the boxes, and your address. But if you are giving a controlled drug, so that applies to opioids, you need to include certain additional information in order for the prescription to be like legally, to be legal, and therefore for the patient to get the medication. So you need to write the form and strength of the medication. So it says here, but diamorphine 30 milligram injection, it's ampules, and then you need to write the amount in words and figures, so a digit and then the word itself. And then you also need to write no more items on the prescription, so that no one can add anything on. And it needs to be signed and dated. But the main things are, you would need to write like morphine immediate release, 5 milligram per whatever mils liquid, or morphine modified release 5 milligrams tablets, and then a indication, the instruction. So 5 milligram tablets, take 1 tablet twice daily. Like you have to write the form, strength, and the directions on the prescription for it to be legal. And again, just go through this in your own time and make sure you know all these things, and the quantity in words and figures. So yeah, that's just a quick note about controlled drugs. TTAs, it said to go through TTAs. This is not really going through TTAs. The basic principle is when a patient gets discharged from hospital, they get prescribed some of the medication to get them through, and then the GP should review and prescribe more medication. You can give them 7 days, for example, of whatever opioid they're on to take away with them. And if it's for a GP prescription to take away, you need to have all these legal requirements on it. I think that's basically what they're getting at here. So yeah, go through that. Again, I don't know if this is worth going through in like immense detail, probably unlikely to come up, but I think if they asked you to do this, they would tell you what the patient had already been on in hospital and just ask you to prescribe the same thing. But you could look in the medicinal forms section in the BNF to choose the most appropriate thing. And worth saying with MST, so that's modified release morphine, So once you've got your patient on 4-hourly morphine with PRN doses, they've got a dose in 24 hours. So let's say they're using 60 milligrams in 24 hours of morphine total. You're sending them home. You need to convert that to, you don't need to, but you could convert that to twice daily modified release. So 30 milligrams in the morning, 30 milligrams in the evening, plus PRN or morph that they can use if they have any breakthrough pain. With your MST tablets, just remember to round them correctly. So you can't give them like 6 milligrams. They only come in 5, 10, 15, 20. So just give them the most appropriate one. And then Oromorph, which they can use in between doses of MST. Okay, other topics, DNA CPR is definitely relevant. Make sure that you practice discussing DNA CPR. So basically just explaining what CPR is in non-medical terms. So being able to explain what is CPR. CPR is used when your heart stops beating. Explain why CPR isn't very effective in most people with terminal illness, why it's not effective, but why it's not indicated and why it's not effective, just to practice explaining that in like non-medical language, because it's actually more difficult when put on the spot than you would expect. Explain why CPR is therefore not recommended, because it would be futile, it would be, it wouldn't be in the person's best interest at that moment, so it's not being recommended. And then explaining the other things like, we will still give you all other treatment. It doesn't mean that we're not going to treat you or we're letting you die or whatever. It's just that we're not recommending CPR. And then capacity. So discussions about capacity, definitely valid in OSCE. So make sure you know what the criteria are for assessing capacity and how to go about that. Advanced care planning, advanced decisions and statements. All of these things should be covered within psych or the module like CVP stuff. But yeah, advanced decision to refuse treatment, advanced care plan, LPA, make sure that you know what those are and the legal stuff around them. And then certifying a death, it says here, I don't think I learned that in 5th year, but you can learn it if you want to. It's pretty easy. It's just like, you check for, there's geeky medics, you check for 3 types of response and then listen for 3 things on the chest for 2 minutes each. Yeah. But I don't think that would necessarily come up, obviously, but it's worth knowing about for real life for sure. So that's basically it. I'd really appreciate if you can fill out the feedback. Sorry that the menu didn't work and that the internet dropped out. Does anyone have any questions about anything? Like morphine or anything like that? Okay, great. Yeah, if no one has any questions, then thanks for coming. Hopefully you get the slides. You can go through them in your own time.
Thank you.
No problem. Thanks for coming. Bye.